So I think we'll go ahead and get started then. I want to say good morning to all of you in Asia and good evening to colleagues in the United States and other parts of this side of the world. I'm really excited to welcome you to the 9th multi-country stigma reduction network, and I think we're particularly excited because we're expecting many more attendees since we've opened this up to other people to join, given the virtual component of the meeting. I wanted to take a minute to also recognize some of the people behind the scenes who've been involved in the planning. Obviously, with us at UCSF, Richard and Charlie, whom you know, if you can just wave your hands, or yeah. And you know, we've had the pleasure of partnering with UNAIDS on this. And today, Quentin is on leave in Belgium, and he's not going to be with us in person. But I'm also really excited that Belice Odamna is here. Belice is working full-time with UNAIDS, focusing on stigma. And I want to particularly acknowledge the fact that she's still based in Nairobi, given travel restrictions, and is joining us in the middle of the night. And so really want to thank you for that and shout out. So I think you can see Belice on the screen. And also the other person who's been working with us as part of the planning team is Harry Prabowo, who many of you know. I don't know if Harry's got your video. I saw your, there you are. Okay, great. So I want to thank both of you, and all of us will be playing a more active role in the facilitation of the meeting. So more about that in just a minute. I'm going to share my screen and have a few introductory slides. Again, thank you for introducing yourself in the chat box. I think it would be impossible to have a meeting and also do introductions in any other way, given the number of people who are attending the meeting. So just give me 1 second here. Okay, so as I've mentioned, this is our 9th multi-country meeting, and I'm really looking forward to the next 3 meetings consecutively, and I think you'll see why as I talk more about the agenda. Today, after opening remarks that are recorded from Quentin, I'm really delighted that we'll have a guest presentation from Dr. Nitya and Greg Carl from IHRI, and they'll be talking about their KP-led services model and also their approach to monitoring quality of services in that model. And then we'll turn it over to Belice to chair the second half of the meeting, and we'll have the country presentations from Cambodia and Vietnam. And that will be our first day. On day 2, we will have a guest speaker from the International Treatment Preparedness Coalition, Solange Baptiste. And Solange is based in South Africa, so she'll record her presentation, but 2 of her colleagues will be available for live Q&A after the presentation. And for those of you that aren't familiar with the work of ITPC, this is an organization that has been doing community-led monitoring for many years and in many countries, and they've been enormously successful in generating effective data from the community to inform service quality improvement in communities and in healthcare organizations. So we're really glad that she's going to be presenting. We'll have the presentations from Thailand and Philippines, and then we'll have the first of our breakout sessions. In some of our discussions with you in our routine country check-ins, we discussed topics that you'd like to focus more on and to talk to each other about. And so one of those topics was to focus on self-stigma and how that affects healthcare service delivery. And we'll have a short overview of the new curriculum from Thailand on self-stigma before we move into a breakout session. Please expect an email from me to also offer us other specific questions about this that you'd like to include in the breakout session, since we'll be preparing the questions for discussion next week. And then on day 3, we will have the presentations from Lao PDR and Malaysia. And the other topic, which came up several times, was to talk more about mental health and the impact of stigma on mental health and services for people living with HIV, and particularly for LGBTQ populations. And I'm really delighted that we'll have a guest presentation from my colleague, Alex Carulian from the Fenway Institute. And then we'll have a breakout session to focus on discussion about mental health and how it can be addressed in healthcare settings to reduce stigma and integrated into programs. Also, please anticipate, as part of the email you'll be getting, and this will only apply to a subset of you, we'll be asking some questions about mental health services and what's available. It's just 4 or 5 questions. And for the purpose of the questions is to provide some context for Alex for his talk, so he has a feel for what is currently available and what is currently part of service delivery and standards for mental health in your countries in HIV services. So please be on the lookout for that. I wanted to also just, since obviously COVID is on all of our minds, and the discussions we were having before we started is to just take a quick look at the region. I think most of you are probably aware of this website, Our World in Data, which is a really great source of information for global data about COVID. And I've selected just a few samples to show you. I think you'll see that I chose countries that are represented in today's meeting, in addition to the United States and all of your countries in Southeast Asia. I also included Belgium, where Quentin is, he's not with us at the moment, and Kenya, where Belize is. But I think also some other countries in Asia to give you some reference points in the region. So I think you can see here that as of August 17th, we're still seeing spikes, and the peak here, Malaysia and the United States and Thailand are high up there compared to the other countries. Obviously, everybody is trending upwards here, but just to give us a sense of where things stand across the board in the region. And again, you can look at this website for more detail. On this chart, I think you can also see that we are living in the world of the Delta variant for now, pending the emergence of newer variants that are on the horizon. These data are to be looked at carefully because the reporting and the sequencing of variants is not done routinely in many countries, and not on all specimens. But I think that where it is done with more frequency, you can see the overwhelming preponderance of Delta variant among COVID cases. And of course, the sad news related to the resurgence of COVID is the increase in deaths. And I can say that, although I'm sure you're hearing about some trends of improvement in the United States, that in many countries here, many states here in the country, in the South, we're seeing both a resurgence of cases and deaths. And like you, we're also seeing hospitals that are at full capacity, again, like at the beginning of the pandemic. And I think, as our CDC director has said, we're seeing a pandemic among people who are not vaccinated, although we are seeing an uptick in cases among people who are breaking through vaccination as well. We know that the vaccinations are successful in preventing serious illness and death in most people who are not immunocompromised. And I wanted to end my few data slides on a more positive note. Although we see this great disparity in the rates of vaccination, both for double vaccination and single vaccination, for those of you who've been looking at this information previously, the good news is that we've gone from single digits to double digits in most countries, with apologies, Belize, since Kenya clearly here is lagging behind. but I think you can see some major trends here moving into double digits in countries, and with over half the population vaccinated in Malaysia and Cambodia among the countries participating in this network, and some benchmarks with other countries in Asia, just to give you a sense of comparison of where things stand. And so again, just I realize it's sometimes hard to see on the screen, but of countries that are here in the network, we have Philippines and Vietnam, Laos, Thailand, and we have Malaysia and Cambodia here. I also wanted to say that, and I think we'll hear more about this from you as well, that we know that COVID severely disrupts other work necessarily, of course, but it doesn't stop the urgency and the importance of the work that we are able to continue to do to focus on stigma. And just today, as part of another quality improvement initiative I'm involved in the state of Louisiana, in New Orleans, where we have a quality improvement collaborative, we had a special talk on stigma and intersectional stigma for the collaborative from Dr. Mauda Monger, who's from Mississippi. I just snagged 2 of her slides as a way to remind us that we still have a terrible problem with stigma, and that it leads to reductions in condom use because people don't want to be seen asking or carrying condoms, that it interferes with discussions that are very important for both HIV negative and HIV positive gay men, where the epidemic is surging in our country as well as in yours, and that it increases infection rates of HIV, since it also prevents people from coming forward for testing and from accessing PrEP and other important treatments. So we know, again, you all know this, but I just want to really reinforce how important this work is, and I'm glad that you are able to continue what you can do in the setting of the pandemic, because we also know, and she borrowed this slide from AVERT, the organization in the UK, that stigma is actionable, and it's actionable on many levels. And I think the work that you do shows us this, that we can protect, include, educate, and empower as part of our work to fight stigma and discrimination. So I think with that, and setting the stage for moving forward and trying to keep an eye on the importance of quality improvement, because it gives us tools in which we can be constantly vigilant in the healthcare setting about whether stigma is present. And it also gives us tools in which we can move forward to implement changes and interventions to embed actions in our health facilities that will keep us on the forefront and vigilant in our organizations to fight stigma and discrimination. And so with that, I'd like to turn it over to Charlie, who is going to project the recorded welcome from Quentin. So thank you for your attention. And I was going to say, oh, hi, Quentin, right? So there he is on video. So take it away, Charlie. Thanks.
No voice. You can't hear. You can't hear.
I'm the Regional Human Rights Advisor for UNAIDS in Bangkok. It is my true pleasure to welcome you on behalf of UNAIDS to the 9th QIS+D Learning Network. Since we met with most of you last year in November, there have been quite a bit of evolutions in the global field of HIV. Just a few months ago in June, the new political declaration on HIV and AIDS was adopted at the UN high-level meeting in New York. The new political declaration has a title, Ending Inequalities and Getting on Track to End AIDS by 2030. And that declaration is actually based on evidence, it's grounded in human rights, and it will serve as an important guidance to advance the global HIV response over the next 5 years. Well, a few months before the political declaration, UNAIDS also adopted the new Global AIDS Strategy 2021-2026, and inequalities and AIDS. And that is a new global AIDS strategy that was designed basically to get every country and every community on track to end AIDS as a public health threat by 2030. That new global AIDS strategy is actually based on human rights, on gender equality and dignity, and is focused to be free from stigma and discrimination for all people living with and affected by HIV. That strategy is the result of an extensive analysis of HIV data, as well as a very inclusive process of consultation with both countries, with communities, and with other partners. And one of the three strategic priorities of that strategy is to break down legal and societal barriers to achieve HIV outcomes, including a target of less than 10% of people living with HIV and key populations that experience stigma and discrimination. And that's why this learning network is so important for us as well. Linked to the new global AIDS strategy, UNAIDS is also restructuring and having a stronger focus on human rights and on stigma and discrimination reduction. With that bigger picture, I would like to also thank Bruce for the great Bruce and his team for the great partnership that we've established over the last years to organize this learning network meetings. And I truly hope that the 10th QIS+D learning network meeting that we will be organizing, that will be in person. Without further ado, I wish you a very fruitful discussion and a very fruitful day. Thank you very much.
Great. Okay. Well, sending thanks over to Quentin in Belgium. So, okay. So I think that I can't see the agenda at the moment, but Charlie, I think we're on to Dr. Nitya, correct?
Yep.
Okay. So without further ado, then it's my great pleasure to introduce Dr. Nitya Panapak, who is the executive director of the Institute of HIV Research and Innovation in Bangkok. And she graduated with her medical degree from Chulalongkorn University and has a PhD in medicine from the University of Amsterdam in the Netherlands. I'm sure most of you know Dr. Nitya and have seen her present at conferences and are familiar with her work. And she provides ongoing research to support studies as the PI in many, many studies. And she's also the governing council rep for Asia and the Pacific Islands to the International AIDS Society. Dr. Nitya works actively with community and government partners to enhance access to HIV testing, prevention, and treatment, and has a deep interest in key population-led health services. She will be joined by Gregory Carl, who is the Senior Capacity Building Supervisor at IHRI, and he's been working in the fields of HIV social and behavioral research and counseling in the Asia-Pacific region for more than 30 years in affiliation with the Thai Ministry of Public Health, Thai Red Cross, the Program on AIDS, and UNICEF. And so without further ado, I want to thank Dr. Nitya and Greg for joining us today. Look forward to their presentation and to questions and discussion after the presentation. So with that, I will turn it over to Dr. Nitya.
Thank you very much, Kat. Thank you very much, Bruce. And it's really my pleasure to be here with all of you today to see many familiar faces and familiar names for those of you who have not yet turned on your video. So very much happy to be part of this webinar, and thank you, Bruce and HEALTHQUAL for inviting IHRI, which today we have I myself and Greg Carl, who will be doing this short presentation, and we will be very much welcoming any questions and discussion. So my role here today is just to introduce you to this key population-led health services concept. But then, so my part will be kind of like the history and the key milestones of key population-led health services in Thailand. Which although we started doing this with the focus on HIV and key populations for HIV, but I think it's such a important basis of how we deal with COVID-19 in Thailand right now, using these community-led health service responses to help lessen the burden of hospitals in taking care of COVID-19 treatment and testing, in which like at IHRI, together with our community-based organizations partner over the past 2 months, we have been doing this home treatment and community treatment for COVID-19 using this key population-led health services model, and it has helped a lot with decreasing the burden within the hospital in order to allow more severe cases of COVID-19 cases to be able to get into the hospitals, to get those hospital beds. So I'm going to just start with this history and milestones, as I said, and then I will ask Greg to take over in explaining in detail of how the capacity building and quality improvement, quality assessment component of these key population-led health services have been conducted together with linking that to stigma and discrimination as well. So for HIV, we started the key population-led health services in Thailand in 2015. And we defined key population-led health services as a set of services that is designed by key populations themselves, as well as a set of services that is co-delivered by members of key populations who are trained and certified in doing so. And this is to ensure that this set of HIV and sexual health related health services are truly needs-based, demand-driven, and client-centered. And by saying that these set of services are provided by trained and qualified lay providers, this is to ensure that services are delivered in a way that it is suitable to specific context of each key population. And when we say key populations for HIV in Thailand, it is probably very similar to the picture of how HIV epidemic is currently projecting in each of our country here, meaning that more than half of new HIV cases in Thailand are now happening in the populations of men who have sex with men and transgender women, including service workers or sex workers as well. And we have seen a poorer HIV treatment and HIV prevention cascades among these key populations, and we would like these KPLHS, the key population-led health services, to be a key strategy to fill in those treatment and prevention service gaps for key populations. So that set of services that I mentioned is designed in order to make the services be accessible, in terms of location, accessible in terms of service hours, and make sure that that set of services contain services that are seen as available for each key populations, meaning that if you're serving transgender women, we will want to see that it's not only HIV testing services that are available, but also gender affirming care as well. And we also want to ensure that that set of services are acceptable, meaning that it is provided in an environment that is free from stigma and discrimination. And lastly, that that set of services must be provided at high quality. So here in Thailand, we kind of like look at the cascade of HIV services from reaching people, recruiting people, testing people, and then treat those tested positive and prevent those tested negative, and then try to retain people, individuals, regardless of their HIV status in the services. And we can see that the key population-led health services model allow us to tailor services at each of these key important steps in the cascade, meaning that we can make kind of differentiate the services to fit into each specific context of each key population to make sure that we use our limited resources most efficiently. And here we also started to talk about this more and more in the past few years in Thailand, making sure that everyone working in HIV program use the status neutral approach to HIV in a way that we put equal importance to people, individual coming in for HIV testing, regardless of their HIV status. If they tested HIV positive, we would like to start ART immediately on that same day of HIV diagnosis to make sure that people reach that zero risk of HIV transmission as soon as possible. And at the same time, for those who tested HIV negative, we also would like to start all HIV prevention measures as soon as possible in order to get people into that negligible risk of acquiring HIV. And by doing this, it means that we will not waste our resources, diagnose people who are HIV negative, and just let them out of the program. So here is the key milestones of KPLHS in Thailand. And we as I already mentioned earlier, we started doing this in 2015 and gradually started in 2018. We standardized the training modules for KPLHS, which Greg will talk into more detail, in a way that we aim for this to be seen as a training modules that will be endorsed at a national level. And at the same time, by showing that we have these standardized training modules for KPLHS, we get the buy-in from three key professional institutions, including Medical Council, Pharmacy Council, and Medical Technology Council, to endorse and support the development of this KPLHS MOPH regulation, allowing key population-led providers to perform certain clinical services. And this was signed by the minister in 2019. And last year and this year, we moved towards getting that MOPH regulation and endorsement, as well as the standardized training modules, towards that being the supporting milestones to allow domestic financing from the Ministry of Public Health through the National Health Security Office, or NHSO, who is the main payer of health services in Thailand, to give direct domestic financing to these community-based organizations where key population-led providers are providing their services. And this is not a straightforward or easy process, and I think we will learn more from Greg's talk later on. And this is my last slide before I hand this over to Greg, just to show to you which clinical roles that the key population-led providers that I mentioned can now perform in Thailand. And this is according to the 2019 MOPH regulations. And you can see here that the clinical roles that our KP-led providers can perform include those not only limited to providing pre and post-test counseling, but they can also collect samples to test for HIV, to test for sexually transmitted infections. So what you can see here is that they can do finger prick blood collection. They can collect samples from oropharyngeal compartments. They can collect urine. They can collect rectal samples. And they can also perform the testing, the point of care testing, meaning that they can do this rapid HIV testing. They can do a gene expert to diagnose gonorrhea and chlamydia, and as that is part of what we call HIV and sexually transmitted infection in this MOPH regulation. And then what is a key component of clinical roles here is that these KP-led providers can also give out drugs, which means that for us here, the pre-exposure prophylaxis, post-exposure prophylaxis, and oral treatment for sexually transmitted infection can be given out, that these medications can be given out by KP-led providers to their clients without the physical presence of doctors in the clinics. So these medications will still need to be prescribed by the doctors. This is what I think is common in many countries, that doing prescription is still doctors' roles. No one can do prescription besides doctors, but the role of handing over that medications to the clients are now allowed to be performed by key population-led providers. So now I would like to hand this over to Greg, and Greg, you can tell me to advance the slides for you.
Okay, thank you very much. Good morning, everyone. I'm Greg Carl. I will start off by discussing our capacity building and certification process a little bit. As Dr. Nitya had already mentioned, that we work in partnership with our community-based organizations and have come together to work to develop the curriculum based on the services that they themselves have designed and are providing. After that they nominate their staff to participate in the training program. And initially we thought that we would target specifically the counselors that would be directly providing services to clients. But most of the community-based organizations, they also requested that we include other members of their staff in the training process so that they can gain a basic knowledge on the services that they need to promote, both within their clinical settings and also during outreach. They then participate in the training program. Again, as I mentioned, that our initial focus was on the staff that were providing reach, recruit, test, treat, prevent, and retain services. So most specifically, the staff providing both counseling or care and support services within the clinics. But then we found a greater need as we've gone along to also provide at least some basic training for reach, recruit, and retrain. So those staff that are providing services in the field or outreach programming, or reach, recruit, test, and retain staff who are perhaps not providing facility-based clinical services, but those that are providing mobile clinical-based services, which they need to provide counseling services and will also provide HIV screening services. After they have completed a series of training courses, for each course they must complete a post-test exam, a post-training exam, and they must achieve a minimum 80% score. for a pass. Those who do not pass have an opportunity to then refresh the training in two different ways. The first way is through an online e-learning programming, which we have developed and are still, some courses are still under development, or depending on the number of persons that may need refresher training or the timing of training of new staff, that we will provide refresher training face-to-face. Of course, during COVID, we can't provide it, I guess, face-to-face in the normal sense, but we've gotten quite skilled in providing online training through Zoom, primarily, and also in our collaboration with the community-based services, that each of our partners has its own training team that we have come together as a collaborative kind of a sub-organization under IHRI called Engage. The training teams within each organization are highly skilled, and they are the first to be trained, first to be updated, so then they can then train staff within their own organizations. After staff have then passed their training courses, they then must participate in quite a lengthy practicum, which involves observation of senior staff within their organizations, and then they need to be observed by the senior staff within their organizations. And then after they are considered to reach a sufficient level of capacity in providing services on their own, they are then asked to collect cases in HIV counseling, or HIV pre and post-test counseling, PrEP counseling, and also counseling for ART. And the culmination of that process, they will then undergo a competency review. And for the competency review, they must also attain a score of 80% from the review, and then be nominated for certification from our certification committee, which is made up of a panel of experts of all from different medical health fields related to HIV. Okay, next slide, please. Okay, this is just to show you the different course curricula. The basic level, we primarily focus on the RR level, so the outreach, leading into the community mobile services. Then intermediate level, also that depending on the level of services that are provided within each organization and within each service, that we've added a bit more, that we've maybe put more detail into training into HIV screening or STI sampling, also in terms of training on PrEP and PrEP dispensing for some circumstances. Then for the advanced level, this would be the level that is the focus of our community-based or our facility-based counselors in the community, that they receive a very intensive training that includes all 6 of these topics. And we have more in line that we see are necessary. That is a continual development process, and we are continually adding on to adding courses into the curriculum and providing them both as pre-service and in-service training programming. Okay, next slide, please. Okay, this is basically focus our first class of KP lay providers that have been trained and certified under Engage that I just mentioned. In total, we train 350 KP lay providers. But from that 350, we have certified 106. And the first question we generally get asked, why have we trained so many, but so few have been certified? Well, the 350 basically are almost all staff within the community-based organizations, that the community-based organizations felt that all staff were in need of some fundamental knowledge related to HIV, STI, hepatitis, and other issues related to HIV transmission and prevention, including in PrEP and ART. From that, those that have been certified are the staff that are directly providing counseling or care and support services on a day-to-day basis. So this will also differ depending on the service, whether they are providing full RT-TPR services, RTR, or in some cases RRR. The advantage of, I guess, providing training to a broad spectrum of staff is that there is staff movement and provides an opportunity which staff can move from outreach into, say, clinical mobile services, and from clinical mobile services into facility-based services without losing a lot of time. We just need to add some additional training to the training that they have already received. So it's been very advantageous for us as we are learning in the development of this entire process. Okay, next slide, please.
So Greg, if I can add to that, just a little bit in terms of the kind of the impact that these trained lay providers has made to HIV, to kind of the coverage of HIV-related services in Thailand. We can say that these trained lay providers are working in, I would say, 10 to 12 KP-led clinics throughout the country for now. And they have contributed to half of HIV testing in the country, as well as they have contributed to 60 to 70% of PrEP uptake in the country. And this is, I think, the important information that have led Thailand in endorsing the roles of key population lay providers here.
Thank you. Yes, I didn't include any of that data, but yes, very important. And looking at the issue of stigma, we have found that, you know, there are some common issues of stigma across the services. And what we have tried to do is incorporate this into our training programming. So each of the training courses will have elements. Of course, we have specific training courses for PrEP and ART, which will target PrEP stigma and U=U stigma, but also these are integrated into our basic HIV course, and also in the basic HIV course and other courses we look at gender stigma. Oftentimes we're asked, why do we provide this? But we must remember that, of course, the LGBT is a very diverse group, both in terms of gender identity and sexual identity. And so we need to look at what are the different values and attitudes of the different staff that are trained under the different courses. And then for PrEP, it's also, you know, at its core is sexual stigma. And then even though that PrEP is more effective at prevention, is also seen as perhaps a less honorable prevention measure, and is often stigmatized within the LGBT community, as well as without, as seeing that people who are on PrEP are perhaps more highly sexually active, you know, have higher risk behaviors, which is not really the case. Of course, then we have different behavioral stigmas, and this could include drug use behaviors. I think it was 2 years ago, there was a survey was done among our community-based partners, and it was really a focus on values and attitudes related to drug use behaviors, because many of the staff were reluctant to ask questions about drug use. And then when a client revealed drug use behavior, there's a quite a bit of hesitancy to discuss it within the counseling services. But by looking at this more closely, we've been able to reduce say counselor or service provider inhibitions in discussing this and able to provide better quality services to the clients. At the same time, we're also looking at what the clients experience from other services. From our services, we also link with government services. So helping to both work with our government partners in reducing the different types of stigma that we have looked at within our own cadre of service providers, but also help our partners to work with government service providers to reduce levels of stigma in their services. The U=U stigma is also based in sexual stigma, and it's includes stigmatizing attitudes towards people living with HIV, stereotypes related to sexual irresponsibility, and intersectional stigma related to sexual minority or gender non-conforming populations or individuals and populations. So which we try to focus more and more, integrate into all our course curriculum as much as we can, but we definitely need to do more as we go along and as new course curricula are being developed. Okay, next slide, please. In looking at quality improvement, we have developed a number of different mechanisms to aid in quality improvement and stigma and discrimination reduction. The first is our training and certification practicum that I just mentioned, that the practicum generally lasts a duration of anywhere from 6 weeks to 3 months. So it's quite a lengthy process because the service provider needs to collect quite a number of different cases. They need to collect a minimum of 20 different cases. So 5 for HIV pre and post test counseling, 10 for PrEP counseling, 5 for new PrEP cases, 5 for continuing PrEP cases, and 5 cases related to ART. And then they must undergo the certification process. In the certification process, we closely look at the language that is used by the service providers, making sure that it is not stigmatizing. We are now focusing particularly related to PrEP and ART provision, looking at gain framing of messages in service provision. We find that gain framing has helped in reducing or promoting the services that we offer, but at the same time, we are hopeful that it's also reducing any risk of self-stigmatization on the part of the clients from receiving the services that we provide. In the certification practicum, that it involves, based on the observation, the new service provider observing the senior counselors, and then senior counselors observing the new counselors. It's based in counselor supervision, but after the practicum period, the counselor supervision continues as needed. Generally, the counseling supervision will take place a couple months before they receive external quality assurance, quality improvement visits, but they can happen at any time as needed during service provision. The quality assurance and quality improvement used to be provided in a collaboration between IHRI and FHI 360, but now we have expanded to incorporate the provincial public health offices and also regional disease control offices to acquaint them with our KPLHS services, but also to advocate or to get buy-in into the KPLHS services and processes. Previously we would provide quality assurance, quality improvement assessments twice a year. We have now reduced that with the collaboration of the government offices to just once a year. Because twice a year with the expanding number of community-based health services has just been, I guess, too much at the present time. During this period, for quality assurance, quality improvement, generally we would have staff do direct observation into counseling services and other services provided. But during COVID, we asked that the service providers videotape with the consent of the clients, the counseling sessions, and send them to the quality assurance committees made up of the provincial health officers and regional health officers together with FHI and IHRI to review and to grade and to provide feedback directly to the staff. Beyond that, we have also incorporated the use of mystery clients. The one thing that the quality assurance, quality improvement process can provide is that it can reveal the capacity of our service providers, but in some ways we may not actually discover the actual quality and service provision due to the bias built in from through observation. So that by having a senior figure come in and observe the counseling process, that counselors say do their best work. What we want to see is what happens on a day-to-day basis. What is the quality of the services that are being provided? So we periodically arrange for mystery clients to go to each of our services to actually see. They have been trained on the criteria that we are looking for in service provision. And then after they have completed their observations, they come back and complete a survey or undergo an interview with us to provide feedback, which then we provide feedback or additional training to our service providers. The mystery clients don't undergo any testing or any services. We generally work in collaboration with the laboratory staff, let them know that a mystery client is coming in, and they're the only ones who will know who the mystery clients are. And so they will provide documentation. I guess that is more of a role play than a real thing, so that we can see, how the counselors process the information and then continue to provide the post-test counseling and other follow-up services. And beyond that after each service is provided, that clients are asked to complete a client satisfaction survey while they are attending the clinic. And these are periodically collected, analyzed, and then also we determine whether or not refresher training or additional counselor supervision or case conferencing may be needed within the service. So this whole process involves a lot of different parties. As I mentioned, engaged. So IHRI and the community-based organizations, FHI 360 is involved. They help coordinate with the provincial public health offices and regional offices of disease control. And then, of course, these offices together with the local hospitals are involved, and the services themselves and the service providers. And so that's that's all I have for this morning. We didn't include any data in this just to keep it brief, but I welcome your questions. So thank you very much.
Well, thank you very much, both Dr. Nitya and Greg. I think, this is, it's a really comprehensive model, which is, I think, what makes it so impressive, in that you've thought through the whole landscape of quality. And I think very often the quality improvement work doesn't often get paired with the training and certification. And so it's really, I think, particularly impressive to see how that all comes together in what I think is, a true KP-led model. So thank you for that. I'd like to open the floor up for questions. I think if you raise your hand, we can start that way. You'll pop up to the front of the screen, and you can also type a question in the chat. So here's a chance to explore any other issue or any issue that's been presented, or any other issue with the experts. So while we're waiting, I think I would like to ask you two questions. One is, I think one of the other things that's so impressive about what you've been able to accomplish is securing the buy-in of the ministry and the Medical Professional Council for allowing non-physicians to perform activities that are traditionally often in the sphere of medical practice. So I wonder if you could talk a little bit about that, and how did you overcome that resistance? I think let me start there, and then let's see how other questions. Again, please raise your hand, and I'll call on people as I see their hands. So can I ask you to go ahead and address that one?
Sure. This is not an easy question to answer because I think
I knew that.
all of us, yeah. But I think when Greg mentioned about engaging the provincial health office and regional disease control office, as well as local hospitals, I think that's probably one of the strategies that we use to get the buy-in, because you need to get the buy-in from the professional institutions, as well as Department of Disease Control at the MOPH centrally, in order to get all these like certification, training modules, and regulations approved and endorsed. However, you also need like voices from the provincial level, voices from those who already have experienced the impact and the benefit of having KP-LHS being integrated as part of their provincial health networks in providing HIV services. And I think that at the end, voices from doctors in the hospital, voices from provincial health office officers are those that we used in order to support our request to have these KP-LHS training modules certified, having these KP-led providers certified and registered at the national level. The NHSO here, who is the main payer of health services, also play major roles in our country in saying that they have witnessed the quality of the service and they want to pay for this, but they just need the MOPH to get the approval or endorsement of these lay providers so that they can start the payment process. But I still have to say that it's not easy. You get like stuck and things kept silence for months, and then you need to send voices, sometimes more aggressive voices to get things restart again and to get the process rolling on.
Yeah, I appreciate that. I know that's just scratching the surface of the process, but I think it's a great story to be told about this down the road. So sometime when we get a chance informally, I'd like to follow up. I've got some questions. Let's start our UNAIDS colleague from Vietnam, Huey. Do you have a question? Would you like to go forward?
Thanks. I think I saw a few hands before me, but anyway, thanks. Also thanks to Thailand colleagues for a very comprehensive and interesting presentation. I'm interested in the slide where you say you describe the government endorsement and commitment for KP-led service provision, and there's a bullet on saying that in Thailand, domestic financing is provided directly to CBO. Can you elaborate a little bit more on that? Is this KP-led service provision model that you have just described is financed by the government, by public funding from the government, and how it happened? Thank you.
That's a great question, and we started this in 2015, and that was started as part of an implementation research, so that we can collect data systematically to use that to advocate for policy change, and I think we have seen gradual transition of the proportion of funding coming to these KP-led clinics, changing from these being totally funded by PEPFAR, by USAID, to now we have seen half or more than half of the funding coming to KP-led clinics for this service provision coming from the government through the NHSO. And this is, again, not an easy process because NHSO is tasked in Thailand to only pay for services provided in the hospitals. So these KP-led clinics are not seen as part of the service providers in the country system. And we have made several kind of detours on how we can make NHSO pay directly to these KP-led clinics. The mechanism that we are using now is that we register the KP-led clinics as a medical technologist clinic, because we have those who are KP-led providers who are also medical technologists. We don't have doctors, we don't have nurses, so we cannot register the clinic as a medical clinics, but we can do that as part of being a medical technologist clinics. So this is the mechanism that we use right now, so that an HSO can at least pay for HIV testing services at these KP-led clinics, directly to these KP-led clinics. The next step right now is PrEP provision, because we know, and the country knows well, that PrEP provision is now happening throughout these KP-led clinics. They have tried to see how to pay KP-led clinics for PrEP provision. It has not yet been successful because we don't have doctors as part of these KP-led clinics, and doctors need to be the one who prescribe the medication. So another detour mechanism that we use right now is that we partner these KP-led clinics with the hospitals within each province, so that the money for PrEP provision came through the hospital and then be channeled to the KP-led clinics. You can see here that this will not be very sustainable because it depends on how the directors of each hospital sees this process. Some hospital may want to be very direct and straightforward in a way that, okay, we understand that you only use the hospital as a way to pass the money from the government to KP-led clinics. But some hospitals may want to take like 10 to 20% of this money into the hospital for administrative costs and only give some remaining amount to the to the KP-led clinic. So again, not sustainable. So this is the mechanisms that we have been using while waiting to make KP-led clinics be seen and recognized as one service provider platform in the country by the Ministry of Public Health and by NHSO. We feel that this may take like a few more years for this to happen, but at least we need to get some mechanisms to get some money to KP-led clinics.
Okay, great, thank you. Got a question from Harry, and then I'll read the question in the chat. We have 5 minutes left, so Harry, I'll ask you to be brief, and then we'll try to get both questions. Thanks, go ahead.
Okay, Dr. Intaya, great. Thank you so much for the great presentation. I always admire about the KP-LHSS being rolled out in Thailand. So I have a question related, as you mentioned, there are 106 community has been certified as a key lay providers, and I just want, and then it has been distributed to the 14 provinces. I just wondering on how you try to measuring the quality improvement not only on the skills but also in terms of stigma discrimination over time, because they are not focused in Thailand. I mean, in Thailand it's easy because but now they are based in other province. Plus, we also heard because of this COVID, we heard there is some country have to dealing with the wrongdoing of test and treat. The implication of that is like the community start to, somehow loss of trust in the key population lay providers, or even the healthcare providers by the government. So how you measuring the quality improvement across these 160 community who has been certified to be continue to be maintained? That's all my question. Thank you.
I will start. I will try to answer this question first, and then I will ask Greg to add on. I think at this moment, we are still like getting into this new phase of getting domestic financing to KP-led clinics. And I feel that that is why we get a buy-ins from not only the KP-led organizations themselves, but also many other players in the country, including like Global Fund, who now also would like to have their CSOs being seen as KP-led service providers and go through this same mechanism that we have established over the past 5 months. So there has been like efforts from different stakeholders in trying to get this certification and QA/QI activities done in order to see that the domestic financing can really get to these CSOs. So Greg mentioned that it's true that only IHRI or FHI 360 will not be able to do this throughout the country, and that's why we engage those in the provincial health office and regional disease control office, as well as local hospitals to play this part, because we see that in the future they will be the one who do this regularly, not IHRI and not FHI 360. And this mechanism can also be used not only for HIV related services, but also for many other services as well. Greg, you may want to add.
Yeah, can I just say before you do, I just really want to underscore the issue related to the sustainability in the subnational level of the country. It's and it's something, you know, there's a lot of questions about sustainability in the chat too. So I think this is something that we want to keep an eye on and learn more from you as this unfolds in the role of the provincial health offices. Greg, go ahead. And then I do have one more question in the chat, and I look like somebody else has also raised their hand, and I will probably run over a little bit before the break, but if I can ask everybody to try to be very brief and succinct. Thank you.
Yeah, building on what Dr. Nitya just mentioned, that I think involving the government offices has been very beneficial. Just recently, we were asked to provide training on PrEP by the Ministry of Public Health, 2 rounds of training, which involved the government hospitals across the country. And we involved the community-based partners as key players. They were actually educating their hospital counterparts about PrEP. And so it's getting more and more government buy-in, but at the same time, helping to work with the government offices or government services to help reduce elements that may lead to stigma and discrimination, not only in the community-based services, but also in the government services. So trying to build a system where both the government systems and the community-based systems can provide feedback to one another. Because oftentimes that, you know, if something is amiss, if someone feels that they're discriminated, they're going to be reporting it to someone. And less, of course, self-discrimination. But I think, as I tried to mention, that we really look at how information is provided during the services, you know, really looking at game framing of messages for PrEP, for ART, for other services, and really trying to reduce the possibility that our services will lead to the self-stigma.
Okay, thanks. Lots more to explore on that one, and I can envision a part 2 of this coming forward as you have more and more experience. And, you know, also I think this other area of the relationship between the community or the feedback from the provincial level back to the clinics, and that sharing of information and real partnership is going to be something that I think everybody will learn a lot from. And there's been a lot of emphasis on community clinical partnerships, you know, in other countries too. So the last question that I want to make sure we cover is that Farozar has asked the question if there are criteria for education for the KP lay providers. He asked for training. So I'm not quite sure. Farzar, do you want to be a little more specific about that? Or Greg, do you understand, and Dr. Nitya, do you understand the question?
I understand it in 2 ways. Whether there's an education requirement for KP lay providers would be the first way. Under the ENGAGE training and certification program, that we really look at the capacity of the individual, so that there is no education requirement. Some of our KP lay providers have many years of experience already, but they do not have the privilege of high education. A few haven't completed their secondary education, but are very excellent workers. The government has now established its own certification system, and they do require, I guess, an education. They do have an education requirement. I believe that they would like to see that everyone has completed their bachelor's degree, but it's still under negotiation. We're trying to get it reduced to secondary education maximum, because some of our providers are, you know, they're doing an excellent job. There's really no reason. They do have the capacity, and they have had very intensive training. For our RTTPR courses altogether, they receive more than 150 hours of training, plus the practicum, plus follow-up, plus in-service trainings, plus the QA/QI. So there's really no reason to not include them.
Great. Okay, thank you. Clearly, again, this is a really impressive model, incredibly thorough, and I think lots more to learn from. I think if we were ever able to pull it off, I think when we get together, it'd be great to have people come do site visits when we're past the pandemic to actually see up front what this looks like. There are some comments in the chat you may want to look at, and thanks, Dr. Anita, for sharing some thoughts about the Malaysian context. So thank you again, Dr. Nutia and Greg. And before we go to a break, I want to now move to that moment that everybody's been waiting for, which is when you get to turn on your camera. So we'll take a screenshot of the meeting and want to make sure that we capture your face. It's a little tough when there's just a lot of, black boxes with white lettering on them. So if we can get you all to turn on your face for us, we're getting closer. I still see a lot of written names here. I don't know. See, we're getting closer again. Okay. Couple more here. Margaret, if you're there, and Sopat, Steve, if you're there. Farzar and Johnson, you're my last ones on here. Oh, wait, I think let's go ahead. Oh, and hi, see Dr. Kat, welcome. So, great. I think why don't we go ahead, and hi, Dr. Alejandria, nice to see you. So why don't we go ahead and take the screenshots, Charlie, Richard, great. And if we're gonna just move to the second screen and then get everybody else who can get on camera, great, okay, yep, picture here and so forth. Okay, great, okay. All right, thank you. So then we're gonna take a break now for the next 15 minutes, and I'm going to ask you to please be back at 35 minutes after the hour. So for Malaysia and Philippines, that will be at 10:35, and for everybody else, that will be at 9:35. Thanks, Charlie, for confirming that. And we'll look forward to seeing you back. And one last reminder for those of you that joined late, please type your name, your affiliation, and country in the chat box. I think we've had quite a few people join late, and so please go ahead and do that. I'll keep reminding you as we go forward. So go ahead, enjoy the break. Thanks.
So good morning once again, everyone. We are now ready to begin our next session. I hope we're all back from our break. My name is Beleso Damna, as Bruce had mentioned earlier, and I'll be your session chair. Like I said, it's my absolute pleasure to chair this session where we will have presentations from the teams in Cambodia and Vietnam, where they will not only present updates from their country, but they'll also give us an opportunity to learn what they've been able to do in the last couple of months and share their challenges, their successes, and some of the lessons that they have learned over the couple of months. So from Cambodia, in the next minute, we'll have representation from the National Center for HIV and AIDS, Dermatology and STDs. The team is ably represented by their director, their deputy director, the head of the technical bureau, and the chief of the technical bureau. I have also seen in the meeting we have representation from the CDC in Cambodia, FHI 360, and the so I would like to welcome the team, the Cambodia team. You will have 25 minutes to present to us your updates and your successes and lessons learned. Then we will have a 10-minute round of questions. So welcome the Cambodia team. Dr. Bora, please. You're welcome.
You're on mute in Cambodia. Yep. Bora, can you hear us? You're on mute. Okay, I see you moving. Okay.
Yeah.
Right, got it. Okay, thanks.
Okay. Thank you, Adana. And on behalf of Cambodia team, we will update our team here regarding the information of discrimination and reduction activity in healthcare setting of our setting. Yeah. And for our outline, we will show the national management strategy and PSS data management use and feedback the data of clients that provider and talk about challenge and next step for our slide. For national management strategy and policy update, we have update our SOP now. In this month, we have a public and endorsed for using at the health facility setting for our that we call patient certification feedback SOP for TLAIV in Cambodia. So these are approved, and for the patient, it's our healthcare more than 170 healthcare staff at the clinic involved in our data by virtual. That those are from the ART clinic, from the community ARV approach, community action approach, and healthcare director of the facility and overall district also has got disseminate on that SOP information. And those are we have 56 ART sites with 87 GA staff of the our partner that we call QIS that have trained and provide this new SOP for how to use that. And we also have the new dashboard that we will show you in here how to work on that dashboard for update that by QR code and patient provide by a scan of that and filling the information on that. Next slide. The system that we architecture here, the tool that we use, that PSS tool will use the cell administrator use side by tablet and some audio in that. And in case that the patient or the HIV patient cannot do or need to assist by our staff at the facility, we will do that. And in case that the patient can work by phone, use the internet and scan the QR code, it's okay, they can do that. So we have many approach that in order to provide that. And in this time, we also work for information from the provider too, not only the receiver. The provider that I mentioned earlier, that we will get back from the ALT clinic staff, and I mean all in referral hospital, they can get the information. And this all information will go through the system that in under control of our national program in here. And when dashboard are created, we will provide the data or the information to the subnational level or to the AT site for the information that get back from those data. And we have some indicator that have detail in here, so you can see later. Yeah. Next slide, the line. This one that example for the number of the patient provide the feedback during the COVID pandemic. So from the Q3 of 20 and Q1 20, the dashboard template has used on that. Q4 2020 and Q1 2021, Q2 21, we can see that the patient from the Q4 of 20, 1,876 cases, and but for the for the Q1 2021, we have 1,082 because of the COVID situation and some areas are locked down, so we have a decrease of the number using. Q2 also decreased more than that. Yeah, it's less and less because of the COVID. Next slide. So these are the dashboard that we designed, and I prefer that our team here, Thailand from FI linkages, APEC, sorry, will show our team how to deal with this dashboard. Thailand, floor for you.
Thank you, Dr. Bora. Let me share screen so that I can. Thank you, Dr. Bora. This is Dalan from APEC HICC Cambodia. So currently, National HIV Program just update the overall live dashboard that collect information from not only the patient but also with the provider. And we have actually 2 languages that you can click here and see whether you want to see the dashboard in Khmer, local language, or English. So this dashboard is mainly aimed to be used by the ALT team leader and the community actions worker at the ALT level to review the data frequently, can be monthly or quarterly, to improve their service based on the data suggestion based on this. So within this dashboard, we can review for, let me change to English. Yeah. So we can see here both patient and also the healthcare provider, the dashboard, and also the patient's dashboard. So here you can filter. So AAT facility or provincial level or national level can filter all of the informations in the dashboard to see the information of the progress update comparison from one quarter to another quarter. So my internet a little bit slow. So here is the information on number of participation for the whole country from Q3 2020 to Q2 2021, as Dr. Bora mentioned earlier. So within this update dashboard, so the ALT team leader at ALT site and also the PhD can actually review by province at the different layer of user, and also review at each specific hospital that they are working on to improve the quality of service. And they can also filter by type of population, including KP, and also the general population and identified population. And they also can review by the 8 group in the dashboard. So this information, as Dr. Bra mentioned earlier, that the number of participants dropped down due to the COVID pandemic community outbreak in Cambodia, and some area are locked down, and further restrictions have been made in Cambodia. So the information's around here, but at least the patient satisfaction with ALT service remain high. It's over 80%, but some sort of concern related to TRIA and register, and also the counselor need to be improved, as well as the pharmacist information down here. The quality of service, I think the quality of time is acceptable. It's pretty high, around 97%, but around the concern of the worry of staff gossip here is slightly increased, but still also the concern for the provider need to improve all of those particular areas as well. For the patient satisfactions, other service, as you can see here, we have ANC reproductive health, we have STI, laboratory, tuberculosis, and psychological support here. The information is slightly dropped during the COVID pandemic, and difficult to access the ALT service during the lockdown as well. And we have some sort of further information detail, but I don't want to go dive into the every single table. And we have further feedback suggestion from the client as well. So the importance of this dashboard is being used by ALT at each specific sites to improve the service and set up the QI. Dr. Bra will present how we interpret this data and put it to the actions point for each ALT facility, and take action and go in follow up to monitor whether the upcoming progress of quarter have been progress in terms of satisfaction and also concern of the patient. I think that's all from my end. Over to you, Dr. Bra. I will reshare the slide presentation. Thank you.
Thank you, Dalan. So we can continue the slide. Yeah, these are the result of the participants from the provider for the result. In the hospital, we can see the Q4 we have 45, and Q1 of 21st we have 60. But because of the COVID also dropped a lot. Yeah. So it's unexpected because of COVID. Yeah. Next. Next slide, please. This one also 4 indicators that we come up from the our database. One is observe of the healthcare worker at the facility who are willing to care of the KP. Yeah, so in the Q1 is higher than Q1 of Q1 21st, and higher than. So mean that now we have improved a lot from day to day. We can improve our healthcare staff to understand our TSS, and after we rule out the SOP that have endorsed earlier, we hope that we have more data than that. And another indicator is related to healthcare worker to provide a poor quality of the care for KP. Also, we can have another on that, and wear double gloves, and worry about the getting in transmission of the HIV. Yeah, okay. So that the data also shown in this 4 indicator. This next slide. For example, in the ALT clinic, that in the Q1 of the quality improvement action plan, we have some improvement achievement. Example 1, 2. We see that area of improvement, we need to improve the there is mentioned about no room for keeping patient record, making the waiting room mess. So the action point will AT team leader we request the hospital director for provide number of locker that can keep patient record, and the action is the team of the ALT there, and they will start in the week 3 of the March 2020, and we have a status, and we can tick on that, complete or not complete, and have some remark about that, and next action will follow up with the hospital director how to improve on that. And example 2 related to triage is a poor organized, so PSS data, so that there is less how many percent certification with the receptionist triage preparation, some that. So the action will the clinic and the team in there that we call CA team will rearrange about the triage system and establish the waiting number of the patient for the use that not burden on this, and who do it the team on that will end the when they will start with week 2 of April, and the status will complete or not complete, we can tick on that. This one for one example that we will follow up. Next slide. So in this for see how are these challenging being addressed. So after do that, we can see the hospital director will use our dashboard that we call PSS data dashboard for join for consult and discuss in the forum that existing forum include like PDCA forum, group of champion forum, that can address all of these issues together to how to solve on that. And UNCHART also have suggest to move suggest for motivate of the counselor skill that will bring awareness of U into the health for all training curriculum. And another point, UNCHART and AT team will lead focus group discussion with the patient who have detectable viral load together with the undetectable viral load to share experience for important of U message, and continue using the PSS dashboard for site operational district. That because these are the new dashboard, but we will strengthen our dashboard and try to provide well understand for the clinic. And for attitude of the fear or the concern and the behavior of the healthcare provider, we will address on that by individual or the group discussion by clear the misunderstand some points. So this will provide an evidence base of U that need to provide the healthcare staff well understand. Next slide. And we also have one video or two video. This one video that we have provide the message about U that we have 10 minutes or the 10 or 9 minutes, yeah, that can share experience on that, that can include the in our meeting for show how to deal on that. And this one also have use social media for campaign and for easy to the everyone understand this movie. Next slide. This one talk about the KP community feedback look. Yeah. So maybe look small, but this this is the table that we create from our setting in here. So we have a lot of system that we need, and we have some point that our partner or our NGO like AACC, APEC, that will provide the community feedback, and all of those will bring the issue from the community and to national program for how to deal, how to work with the complaint or the patient in the community. And the system that we designed, yeah, that this one include like global fund money that can provide to our partner to deal on that activity, and everything will come up to national program for solve that problem. Okay. So for this scenario, we can see that we have a feedback tool and scorecard that will use during community action or feedback from that. And this part we can thematic area of the tool. We have include SCI, ATS, prevention and social protection, and care and treatment, human rights, GBV and IPV also include, and stigma and discrimination also. Yeah, this one the thematic demographic that we designed. Next slide. Yeah, and we also have some challenges that we saw that because of the COVID, the number of the patients participate in our data is very less, and most of provider occupy with the COVID response. And our PSA national team has not been able to conduct the coaching or monitoring face-to-face, but has conduct and use that e-monitoring, yeah, some site. And we have limit number of the provider participate in use of the provide data or deal with the stigmatizing behavior and stereotype. Yeah. And for the community KP scorecard by KP and PLAV community network, we have coaching to relevant provider based on the scorecard. It's part of the action plan for the comprehensive community response. Another slide. Yeah, for our next step, we produce the QR code for the patient, and you use a QR code for health care staff too, that can easy for them. For the healthcare staff, I think we experience that 100% of that can use the mobile phone by scan the QR code. So the result is not difficult, but some the patient will difficult. So we will continue the you awareness campaign by social media or by team to do that, and continue to promote the HIV-friendly service to reduce stigma and discrimination and increase access and uptake the HIV prevention and treatment service among KP. And we will expand the use of QR code to provide the feedback and patient and facility healthcare staff provider. And for the TA, we also still need to provide and monitor to use our PSS to improve the site-specific quality improvement. And we will use the e-monitoring tool for monitor and coaching with the healthcare provider. This is for our plan for next step. I think that's all from our team here, and thank you everyone for your listening.
Thank you very much, the Cambodia team, for that interesting presentation. I think one of the things that stood out for me was to see the documentation of areas for improvement and action points. For instance, one of the things you pointed out is the keeping of patients' records. And the steps that you have taken to address that. And it is also good to see that healthcare providers are engaged and provided with feedback, and they are offered clarification when there is need. I can say we've also been active in the chat, and I see participants speaking about the providers' feedback on stigma and discrimination, which is really important. We can also see that these issues are quite similar in other jurisdictions, and we can also see that one participant says that eliminating judgmental attitudes against people living with HIV and key populations is something that takes time amongst even paramedics and doctors. And so it's really interesting to see the kind of issues that cut across the board. So now I will open up for questions from participants. Would you kindly just either write your questions for the team in the chat, or raise your hand, and then we will they will provide feedback. Before I see any hands up, I'm going to take the question from the colleague in China. The question is, what kinds of measures are used if people living with HIV complain that they are waiting longer for services, when they're waiting longer for services? So kindly, the Cambodia team, would you kindly respond as we wait for other questions?
Yeah, thank you for China team, China team for the question. Actually, for long waiting, we have some solution. Because of the COVID situation, we are not specific on that. But actually, we have, in case that a patient has a lot, we plan to use the spacing, AOV spacing, like a multiple month of the AOV to provide to the patient is more than 3 months, up to 6 months, that can be used for the queue of the patient in the hospital. And during the waiting, we plan our PSA. We plan to have show the data that result of the healthcare staff that complain, that so the patient can see what that medical doctor complain. So in this time they can enjoy on that and can play the tablet for the next comment. I think maybe our team can add, maybe Steve or the land.
Okay. You're done with the response, right?
Yeah.
Okay, great. And I can see a response that patients are encouraged to provide feedback at every visit or when needed, and then this data can be reviewed in a quarterly basis. I think that is also really impressive. Any other questions from the participants? Okay. In the absence of, sorry?
Actually, I can answer that we use monthly data. I mean that every month we'll collect the data from the clinic and report to our national program every quarter.
Thank you very much. In the absence of any other question, we are going to move to the to the Vietnam team, where we will hear their presentation, also giving us an update, challenges, how they've been able to address them, and how to move forward from there. So for the Vietnam team, I can see that we have the Vietnam Authority of AIDS Control. I see we also have representation from the UNAIDS country office, PEPFAR. I think I also saw FHI 360 and VNP Plus. So I would like to request the Vietnam team to give us their presentation, and if there are any issues that are of similarity with the Cambodia team, I think we can then respond to all of them at the end of the Vietnam presentation. So Vietnam,
Okay.
welcome.
Okay, thank you. Good evening, Bruce, Charlie, and friend US. Good morning, everyone. Today, Vietnamese team has a lot of participants from VIC, US CDC, UNAIDS, PEPFAR, HIVN, Hanoi Medical University, and VNP Plus. On behalf of Vietnamese team attending this meeting, Ms. Phượng and I will share with you some information about what we have done for implementing QIS+D activity recently. First of all, we would like to provide you some information about the COVID-19 pandemic in Vietnam. Vietnam is undergoing a Delta wave that began in April this year. Up to now, Vietnam has more than 300,000 cases from less than 3,000 total from before. And now we have about 7,000 people died from COVID-19. Like many other countries, when coping with the COVID-19 pandemic, it is our biggest challenge to our being able to implement HIV, QI, and stigma activity well. Health system and healthcare workers are all deployed to COVID control. More specifically, the impact to the HIV program and to patients has been significant. Many health facilities are under lockdown restrictions, curfews, and social distancing means that people cannot travel normally, resulting in many HIV clients who live in industrial zone or lockdown area not being able to easily access their medication, community, or services. We also see that with the economic center like Ho Chi Minh City under severe strain and going into 8 weeks of social distancing, many migrant workers include people living with HIV and TB who are unemployed and must return long distance to their home provinces, where HIV services are not readily available or accessible and leading to disruption in treatment. Compounding the situation on the ongoing transition of HIV program and client to social health insurance is creating other stigma hotspot and disruption to care. Clients are being told to leave their current health provider to obtain reference or services care at the appropriate district health level health provider. This often not to clients' preference. In addition, health insurance for people living with HIV, HIV is also effective because many business or enterprise in Vietnam, they buy health insurance for their worker every 3 or 6 months only. It means when distancing lockdown or their factory closed, they did not continue to buy health insurance for health worker, for worker. ARV was also a problem, leading to short-term ARV supply shortage, leading to deep insufficient ARV supply, resulting in reduction in multi-month dispensing and even monthly medication supply. All this contribute to significantly to the ability to retain clients on treatment and their receipt of services in friendly and confidently manner. Despite this system pressure, we have seen progress in our work in critical area. Here you can see that we are ensuring that the policy framework allows for robust implementation of effective innovations. We continue to ensure that HIV service providers are committed to S&D reduction in their facility. We recently released guidance on TB-friendly service that provide a clear checklist of the activity and doable measures that facility can take to make sure their service are friendlier. Finally, we are developing national guidance on the committee advisory we call CAP, which will speak to later in the presentation. We now have Stigma index data available and community-led monitoring findings soon on its way. We are ready to launch our lab's heart. Our lab is heart. It is a national campaign to highlight the use of biomedical prevention as a way forward to end the epidemic. We are also excited to that the PrEP program will implement PEPFAR. On-site will report to 7 key indicators on client uptake, retention, satisfaction, and waste time. This will provide us how PP assess HIV prevention care. In the next part, I would like to invite Ms. from HIVN to share some more detailed activity.
Hello everyone, and thank you, Dr. Tri. So as you can see in the slide, so we implement the facility S&D QI currently in 6 provinces. So we start in 2018 and now expanded into 6 provinces total. And in the provincial level, we also graduating the major well-performing site to the high-needs site as well. And we started this model in Bình Dương province and will expand the shifting from major to high-needs sites in other provinces as well. Next slide, please. And since the last network meeting in November, there was 5 provinces conducted S&D assessment and covered 22 sites, and the QI projects currently being implemented. And we will show you the data and QI intervention later. Next, please. So to have the better result, we did implement the monthly methods for assessment. So from last year, we pilot the self-administered questionnaire where the client will do by themselves using the QR code or survey link access. And they also have the support from the peer and healthcare worker in accessing the survey and make clear the content of the question. So even for this model, we need the support from a peer or healthcare worker, but it still see very better result. And we also continue the standard method where we did the assessment for both healthcare worker and the clients. And for this standard method, we did in 5 provinces with 16 sites. Next, please. And here we are showing you the data from the old site and the new site. So in the New side, you can see in the right that the fear of infection through touching or drawing blood or even overprotection is quite high compared to the old one. So the old one at the baseline is also very high, but after the after the QI intervention, you can see the reduction of all three indicators here. So next, please. And the observation of SND, you can see is also much higher in the new side in the graph in the right. This is not very surprised because there is no intervention yet to improve the knowledge and attitude of the healthcare worker. Next, please. And in this slide, you can see it's an indicator about the policy. So adequate supply is quite high for both both new side and old side because now it's in COVID-19, so everything is ready for the healthcare worker. But for the policy written guideline at the facility, we can see that in the new side is very low. The knowledge and awareness of the healthcare worker about their own guideline to protect HIV is quite high. It's quite low compared to the mature side. Next, please. So we also asked a series of questions on how the healthcare worker think about the KP, including the adequate training to work with the KP. And as you can see, the consistently in both MSM and TG, the percentage of healthcare workers reported not receive adequate training to work with KP with more than 50%. But after providing SOV training, this number is reduced to 37%. And we also, in the future, will include the question on confidence in working with KPs after the training and other intervention as well. So next, please. Next, please. Next again, yeah. So shifting to the clients, a major focus on our work last year is about the health literacy as a proxy for service quality. And we mostly focus on the viral literacy. And through the QI work, we can see a significant increase in the knowledge, both the knowledge on their most recent viral test result and routine viral testing interval time. So next, please. Yeah, the slide above is in the major size. How about the new size? For the new side, we see that the baseline number are very much lower, and it's providing us the evidence to design a tailored QI plan to improve these indicators. Next, please. And this time we also added the question on U equal U. So the two questions is, are you familiar with the concept of U equal U? And did you hear about U equal U from your healthcare provider? And we see that the percent of the client not familiar at all with the U equal U is quite high, it's about 40%. And from 40 to 52% reported not receive any information from healthcare providers. So this number is a little bit shocked because in Vietnam we have a national campaign and a lot of programs in improving the knowledge on U equal U. Yeah, so next, please. And through the different methods, of assessment, we also see some interesting results. As you can see in the slide, we have the interviewed and self-administer, and we observe that the self-administered questionnaire have a higher reporting of experience of stigma, and it is something we will explore further. Next, please. And we also document the community stigma regarding to PrEP, and we did into province Ho Chi Minh and Bình Dương, and the indicator here to see that you can see in the pink color and the red color is the agree or strong agree that they are the people they know has experienced with negative judgment in the community because they are the person they know take the PrEP, and the number is quite high from the 32% to 62%. So next, please. Yeah, to summarize the facility S&D component, with the finding we share and the broader assessment result inform our current efforts. And we are expanding the successful survey training to give the healthcare worker more confidence to work with KP in Vietnam, especially for the MSN and TG. And we also promote the S&D government through the wide-scale development and implementation of facility S&D or the client rights policy. And we also still focus on improving the violent literacy and US. Next, please. Here you can see the client feedback in our program. And at the middle of the slide, you can see that it is the community voice where the CAB or the CAP is a representative. So it is a critical component of our work in creating client feedback. So the CAP in charge of collecting different feedback from different forms, and then they combine the data and bring this data to the CAP meeting where they will discuss with provincial CDC and facility to find the root cause and the solution to improve and address the issues. Next, please. And due to the successful model, CAP model in the Bình Dương, the first pilot provinces in 2019, until now, we expanded into 6 provinces. And from this September this year, the VAAC will standardize this model and will expand to whole country, 63 provinces. And now we are at the process of developing the guidance and advocacy for national CAP expansion. Next, please. So CAP is support to implement the multi-strategy to ensure the treatment continuity. So CAP negotiate the after-hours service due to the insecurity of ART. So they have to come to the clinic to take the medication monthly or even weekly. So it's a little bit difficult for many clients to come. So CAP negotiate after-hour services, so every client can come even after work hours, or their family member can collect their medication on their behalf. And they also assist in providing vital information about social health insurance, so the client know how to sign up or where they should go. And in the COVID situation where some facility was locked down temporarily, they will also navigate the patient to the new clinic where they can get the services. And due to the COVID lockdown, many clients cannot go out, and the CAP member collaborate with the provincial CDC and the facility deliver the ART drug. It's very strict because if you want to go out, you need to have some issued travel pass and requested from our authority. Otherwise, you will have to pay the fine, and the policy will ask you so many questions. And the CAP, with the support from the provincial CDC, they have the issue travel passes and the vaccination, so they can deliver the drugs to the client due to the restricted lockdown areas. So next, please. And we also implement the community scorecards. And the CAP also facilitates this model, which we see the healthcare provider and client working together to score the same indicator and then have the dialogue together to improve the score. And as you can see in the slide here, so over 3 rounds, the HIV commodities are now provided in clinic where they previously hadn't been available. Yeah, you can see the number, the point here is 1 and now all of them are 10. So next slide, please. And through the joint scoring, the friendliness of the services is also monitored for improvement. And as you can see here, the clinic and CABs works together to make the site improvement and promote the information and outreach through the different digital platform, as well as improve the confidentiality for clients. Next, please. Yeah, so last year in Vietnam, we implemented the 3rd round of the Stigma Index, and we did in 7 provinces in Vietnam, and it captured the experience of over 1,600 HIV, and it provides the valuable information about the not only community stigma, but also healthcare stigma and self-stigma as well. So next, please. So here you can see that the stigma index findings confirm the KP vulnerabilities. So in the graph, you can see here the MSM and TG are more likely to report healthcare stigma and discrimination compared to other groups. The red one is the percentage of whole sample, 1,600 respondents, and for TG and MSM is about 33 to 41%. And we also see that the impact of the COVID pandemic, with 3 out of 10 reporting they are unable to meet their basic needs. And this number is even higher for TG and female sex worker as well. And self-stigma and mental health risks are also a notable worry. Yeah, so next slide, please. Yeah, and here's the number we found in the SND experience at health facility in the past 12 months. So at HIV specific facility, its number is 24, and at the non-HIV specific is 15%. And most of the reason we found is related to the social health insurance. And the data and the finding and recommendation will inform us to the mental health and self-stigma intervention, which focus on the young MSM and mitigating the impact of health system disruption on HIV. For example, the social health access or treatment continuity, etc. So now back to Dr. Thuy.
Yes, thank you, Phượng. Hi, everyone, again. Now I would like to share some information about the CLM community-led monitoring in Vietnam. After a year of planning and design in consultation with the key stakeholder, the community-led monitoring initiative has just begun data collection for the first round. 22 KP people living with HIV experts collecting the data in 11 PEPFAR provinces. PEPFAR ensure coordination with other initiatives on community monitoring to maximize the number of sites and response. CLM scope is currently on PEPFAR supported services, but there is potential to expand to global fund and national side in the future. As you may know, in Vietnam now we have 33 provinces supported by Global Fund. So we are planning to expand this model in the future, at least in Global Fund province. CLM reports are shared quarterly with government and PEPFAR implementing partner to inform their QI plan. There will be notice to site, provincial authority, and stakeholder if urgent matter needs immediate attention or action. For example, supply shortage, inaccessibility, or serious stigma and discrimination. There are two questionnaire with slightly different monitoring client satisfaction and friendliness of services. Both public and KP website are included in the initiative and will provide a comprehensive picture of client experience in PEPFAR support sites. As we conclude our Vietnam update, our priorities in the next 6 to 12 months is to address urgent needs of people living with HIV and KP, both for COVID and HIV needs. This involves scale up best practice and innovation within province, so health structure for sustainability. We integrate PEPFAR data. We will gain more comprehensive sense of the quality of all HIV services and incorporate them into short and long-term goals. More broadly, we are undergoing a programmatic indicator review to refine and focus on common goals for COP21. We are also answering the program committee monitoring and stigma reduction efforts tailored to the disruption we see during COVID. In addition, VIC will focus on sustainability approach for this work. CDC, HIV, and PEPFAR will refine the program strategically, and we are also working on expanding community investment through CAP expansion. Finally, on behalf of VIC, Ministry of Health, I would like to thank PEPFAR, US CDC, HIVM, Hanoi Medical University, VNP Plus, the EPIC project, and many other organizations and individuals has accompanied with us in implementing QIS+D activities so far. Also, on behalf of Vietnamese team, I would like to thank you all for your attention. Okay, if you have any question, please ask us. Yeah.
Thank you very much, the Vietnam team, for a well-coordinated and comprehensive presentation that's really good. It's also some of the things I know I picked from the presentation was that, of course, COVID-19 has had a huge impact on HIV services, but I do hope that the systems that we already have in place in the different countries could help mitigate that impact. It is also good to see the use of the community scorecard. It is good to see service providers and those seeking services working together to improve the quality of services that are being provided. Of course, also the community-led monitoring, it really shows the importance of working together with communities of people living with HIV and key populations to improve the services that they are receiving. I also noted that in the observations from the surveys you have done is that in new sites, for instance, the attitudes of healthcare workers with regards to people living with HIV and key populations. So what that shows is that there is really need for capacity building on HIV, stigma and discrimination, and even human rights. And of course, we've really also had a vibrant conversation in the chat. I've seen the importance of literacy and quality improvement. I saw Bruce ask whether questions regarding key population stigma have been included in other healthcare worker surveys in other countries. I've seen Malaysia has said yes, and Cambodia also has the community scorecard. So to start off the questions, we have at least 7 minutes to take questions. So the first question I see for the Vietnam team is, what are the measures that you have used, measures used by medical staff to protect the privacy information of people living with HIV in the ART clinic? In the ART clinics, the question has a scenario: will healthcare providers request for the full name of the person living with HIV? So you can respond to that as kindly raise your hand or put your question in the chat box. So Vietnam team, would you like to respond to the one question in the chat?
Yeah, so thank you for your question. So in terms of privacy information, we have several ways to collect this information. So we have the question in self-administered questionnaire, which we do routine 6 months or 3 months. And we also have the question in the CAP. So in the CAP questionnaire, whenever they go to the OPC or to the clinic, they ask for the feedback of the client, and the client will share their feeling and their concern. So we have the both qualitative information and quantitative information as well. So let me take an example. So from the CAP, taking every time they go to the clinic, they found that a lot of clients share that they the healthcare staff calling their full name in the out loud speaker, and they feel very worried about disclosure of their status because they have other friends or colleagues or someone they know may go to the clinic or the healthcare worker to get the examination. So after receive the feedback, the CAP meet with the healthcare staff and the provincial CDC. So 3 partners working together and discuss how to improve this one. And for example, in Bình Dương, after discussion, they change all the name of the patient to the number. So they prepare a lot of a list of order number. So every time the client go to the clinic, they can take one number, and the health staff will call by number rather than the full name. And from the quantitative, we also see, for example, in Haiphong, where we see that because of the clinic is quite small, and people waiting outside can hear all the information inside, where the healthcare staff are talking to the client, and they feel not comfortable about that. And we also work with them to improve this one. For example, they can open a music, very soft music. So if we sit outside of the clinic, they cannot hear the information inside. Yeah. So hope the information answer your question.
Thank you very much for that really quite comprehensive response to the question. Harry, I see your hand is up. Or would you like to ask your question? You can unmute yourself.
Yes, yes. So first of all, I would like to express how thrilled and excited I am to see so much progress that's happening in Vietnam and Cambodia. Especially in the Vietnam is the role of CAP in the QI is really now come to the certain level that they have an equal level of roles in terms of the stigma discrimination reduction program there in the Vietnam. And also in Cambodia, I so exciting also to see the dashboard that comparing them previous person. The last time we have a similar meeting that we conducted previously, the dashboard is quite significant progress that come up from the Cambodia. So my question is first to Vietnam. I just wondering, you mentioned there is for CAP in Vietnam they will be developed on the guidelines or guidance on advocacy. So I was wondering what are sort of what this guideline consists of, and then also can explain a little bit more about the process that you undertake to develop in this guideline. And for Cambodia and Vietnam, I have a similar question basically. So, in order for the stigma discrimination reduction programs able to produce a significant impact, multi-stakeholder cross levels should be understood and to be updated. And I'm just wondering what sort of platform that you used to report this report that you're obtaining from the QI and other SND programs, including from the community side. Thanks.
Cái này em trả lời hay là anh trả lời?
Anh trả lời câu hỏi về CAP nhé, guideline.
Anh trả lời. Okay. Okay. About the question related to the CAP guideline. As you may know, because we have and VIC and as a partner to implement CAP model for several years. So after piloting in some US CDC province, we think we need to expand this model to other province. Not only in PEPFAR in CDC province, but on 11 PEPFAR province and even in other government sites. So in order to implement this model, we need to have a national guideline. So now we are developing this guideline and will issue this guideline in the future. So the province, in health facility know step by step how to implement the CAP model.
Sorry,
can I add just one thing? I'm sorry, this is Asia from the CDC Vietnam team. I think what's exciting about these guidelines is that try to take into consideration different resource needs. So not all provinces are the same, and they may have different resources, both human, financial, and technical. And so the idea of these guidelines will be to maybe come up with key features or key goals that a CAB could achieve, and then working on the context, the local context that they have, they will implement the model that makes the most sense to them. But given that they will have key components like a focus on quality improvement, idea of routine client feedback to inform programmatic focus and programmatic change. So those kind of things will be consistently recommended, but it will be given up to the provinces to initiate how they see fit given their context.
Thank you very much for that contribution. I've not seen any other hand raised, but what I want to do is give each of the teams at least 60 seconds to give us any closing remarks. So I'll begin with the Cambodia team. Please, any closing remarks, any question that you didn't get an opportunity to respond to, please go ahead. Cambodia, please.
Yeah, thank you, Adama. Related to the system that we translate our dashboard, we have a forum that use that dashboard every quarter. At the health facility, we produce that dashboard and we integrate that result of the dashboard into our existing forum that we have PDCA or that CQI and group of champion meeting that can solve all of those problems every quarter. Yeah, this one but respond to the question from our team. In case that our APEC team want to add, please. Align or still, if you have any comment or add, please.
Okay, looks like there is nothing else to add. Thank you. Vietnam, any final inspiring words for the participants, please, Vietnam?
There is still one question about the platform.
Yes.
I think that yeah, we use the Google form to track the QI intervention at the site and province. And I think that in the future, when the CAP guideline established, we will use the Google form for the CAP to do the to get the feedback from the clients. And this Google form will be shared to exercise and CAP and provincial CDC, so everyone can take the result and information, and they will discuss. And the QI information will also store in the Google Docs as well, Google form as well.
Thank you very much. Just a quick run through the chat. I can see that it is really important to point out adaptation of national guidelines and policies. I note that CAB guidelines will also include the CSC approach, and I can see from Harry that he points out that there is need for synergy across the board to ensure that guidelines developed can use the CAB approach, and he's also asking if this information is shared with stakeholders. And I think that is something that we can keep responding to in the next couple of meetings that we have. I see there will be quarterly meetings, but generally, I think I would like to thank both the teams in Cambodia and Vietnam for really the great presentations. I think there is consensus that there is great work going on in the countries, and that the teams have done a good job in documenting the processes and the progress that has been made. I would like to thank all of you for allowing me to facilitate this session. I am happy about the robust participation, the opportunity for cross-learning, which has been exhibited, and I hope that the upcoming sessions will be as interactive and offer an opportunity for more lessons across the board. I would like now to hand over the meeting back to Bruce for the wrap-up session.
Thanks, Felice, for the outstanding facilitation. And I was about to type, I can really only add my thanks to everybody for their participation in the meeting and for the really excellent presentations, both our guest presentation and the country work. And, you know, in spite of all of the disruptions from COVID, it's really wonderful to see that there is progress and there's forward motion with the Stigma work. So, so thank you. Congratulations on the great work. Please keep in mind that we will be sending out an email asking for a little bit more information, really short again, to some of you about mental health services, and really look forward to seeing you next week. Richard, Charlie, anything I've forgotten here?
Just a friendly reminder to please register for each day of the 3-day network meeting. So with the registration link, please go into it and then indicate the next 2 days and please register. Thank you.
Well, have a great day, everybody, as we head to try to get a little bit of rest here on the other side of the ocean. So take good care, everybody.
Thank you. Bye-bye.